Hello. Now we're going to turn to talking about some of the newer, more modern types of antidepressants. Primarily, these are what we call selective serotonin reuptake inhibitors. There are some others we'll talk about here in a minute, but this class of drugs really is the go-to drugs for treating depression. In fact, they're probably almost overprescribed. In fact, a study not long ago found that in the United Kingdom, you could find traces of Prozac in the drinking water in Great Britain. Now, I'll let you figure out how it gets there, but just keep in mind that most of our drinking water is recycled. So these are drugs that are used quite a bit and probably overused and underused in some cases. And so I think it's important for us to understand them, understand what they can do and what they can't do, and how their use is probably appropriate in treating major depression. What their use probably isn't for is long-term constant treatment. And so there's some question about how best to use these drugs, but it's important to understand what they are and how they function. So let's take a quick introduction to the drugs we're going to talk about. These are the SSRIs we're going to talk about. Fluoxetine, which is Prozac, it's also marketed as Serotonin. Sertraline, which is Zoloft. Paroxetine, which is Paxil. Fluvoxamine, which is Luvox. Citalopram, which is Selective. And Citalopram, which is Lexapro. This is the new class of antidepressants that we're going to spend some time talking about. Obviously, most of you have heard of at least one of these. Some of you have taken them. Some of you have friends or family members who have taken them. And so I think it's important that we understand what they do and how they function. So this is a class of drugs. I want to give you a quick overview of the problem with taking some of these and talk about the side effects. And then we'll get into talking about their mechanisms of action, some other issues with SSRIs that are known, and try to put some of this in perspective. Then we'll talk about each of these drugs individually and get into a little bit more detail. But all of these drugs that are listed in front of you are going to have some of the side effects that I'm going to talk about next. First thing is they can cause sedation or even apathy. I know a family member that was taking Paxil and just felt like she had no emotion whatsoever. And so wasn't comfortable taking it and switched to Zoloft instead. There is possible cognitive impairment from use of some of these drugs. Weight gain is a serious complication that can potentially happen. Sexual side effects are probably the most significant side effects that result in noncompliance with taking the drug. In particular, males will have either difficulty getting an erection or ever achieving orgasm. And if there's anything to make a man or a woman depressed, it's not being able to achieve an orgasm. So we don't want to have that side effect. So there is certainly some issues with how these drugs affect us. It's possible that they can make some people manic. When we talk about bipolar disorder, we'll talk more about what mania is, but obviously just makes them high and a little bit crazy. There can be withdrawal. Certainly Paxil, you have to step off of slowly from Paxil. We don't want to just drop off of that particular drug. They can disturb our sleep. There can be some physiological problems, blood pressure, heart rate, those kinds of things. And in 2005, a black box warning was added to these drugs that they can result in suicidal ideation in children and adolescents. And this applies to the entire class of drugs. We haven't talked much about the FDA and its role in these drugs. Obviously, that's how drugs get approved, but it's also how drugs get labeled. It's also how drugs end up with other formulations. So, for example, Serotonin is Paxil, but marketed towards treating premenstrual dysphoria, even though it's the same drug. They're just trying to get you to not buy the generic. It's really what's going on there. Remember, it's almost always about the money. But these are some serious side effects, and there's certainly something to consider. If you look at the side effect label on an SSRI, you're going to get about a 3-page thing of potential side effects. So you want to be careful. These are the serious ones. These are the ones to watch out for. All of these drugs have similar mechanism of actions. Their final common result of blocking serotonin reuptake and then enhancement of postsynaptic serotonin activity at all serotonin receptors in the brain. 5-HT1, which is one of the types of serotonin receptors we talked about, is the one responsible for antidepressant and anxiolytic properties. 5-HT2 and 5-HT3 seem to be associated with adverse effects. 5-HT2 seems to be associated with insomnia, anxiety, agitation, and sexual dysfunction. So if we're having an effect on 5-HT1 and 5-HT2, then we're having the antidepressant but with significant side effects. So when we talk about which of these drugs affect which neurotransmitter, it's important to understand some are good, some are bad. And finally, 5-HT3 can be associated with nausea. So have to really watch how these drugs affect an individual, because not everybody's going to be affected by these drugs the same, and some people may have more of one neurotransmitter versus the other, and so it's important to watch out for. So that's the general mechanism of action for this whole class of drugs. Some affect one of these 5-HT1s or 5-HTs more than the other. So that's where some of the differences in how they function comes across. Really important thing to watch out for in this entire class of drugs is what we call serotonin syndrome. And this happens in high doses, or sometimes when drugs are used in combination, can produce a serious exaggerated response, which includes altered cognition, disorientation, confusion, hypomania, delusions. People feel like they're just losing it. Can be behavioral alterations. People become agitated, restless. There can be autonomic nervous system problems, fevers, chills, sweat, diarrhea, hypertension, tachycardia. Really significant side effects. And this, again, particularly happens if people have taken too much of these drugs, or if they're taking two drugs in combination, which result in too much serotonin. That's why it's called serotonin syndrome. There can be neuromuscular problems, including ataxia and hyperreflexia, that is, people are hyperreflexive. This can resolve in 24 to 48 hours, obviously, provided they're not continually taking more drugs. So it usually needs to be something that's thought about. So serotonin syndrome is very serious. Another serious problem with these drugs is what's called serotonin discontinuation syndrome. These drugs cannot be simply quit. You can't just stop taking a drug because you don't want to take it anymore, because you can end up with this serotonin discontinuation syndrome. There are 5 core somatic sets of symptoms, that is, these are body-related symptoms. People get dizzy, they have disequilibrium, they can have nausea and diarrhea, again, probably due to that 5-HT3. They can have a flu-like symptoms, tired, lethargic, headache, chills, sensory disturbances, including sensations of electrical shock. People feel like their skin's being tingled or electrocuted. And then they can have sleep problems, including insomnia and very vivid dreams. So very clear to follow doctor's orders in terms of discontinuing these drugs. As I mentioned previously, one of the significant side effects of SSRIs is selective serotonin reuptake inhibitor-induced sexual dysfunction. Often associated, sexual dysfunction itself is often associated with major depressive disorder. People that don't feel like doing anything don't feel like doing anything. And so oftentimes people will report inability to be satisfied by sex or lack of interest in sex as part of their symptom of depression. And unfortunately, SSRIs can exacerbate that problem. Up to 80% of patients treated with SSRIs exhibit some sexual dysfunction, including problems with having an orgasm, getting aroused, having any desire, getting an erection, or having any interest in sex. In males, there's a particular problem. It's called an ejaculatory dysfunction, is the most prominent. That is, they just aren't able to achieve an orgasm. And so that's obviously going to be uncomfortable for a male patient. Significantly, or most importantly, this can result in reduced compliance with drugs because, let's face it, people like sex, and taking away that ability is going to be a significant problem. So this is a clear problem with all of these classes of drugs. Now, I want to put a little bit of this into perspective. We don't know everything about these drugs. There are known knowns. That is, there are things that we know. We know. We know these drugs relieve depression for a great number of people, but we also know that they have significant side effects. There are also known unknowns. That is to say, we know things that we don't know, but at least we know that we don't know them. That is, we don't know exactly why these drugs alleviate depression. We don't know what causes depression. We have some good theories, we have some good ideas, and those we've talked about already, but it's less clear about what we do and don't know. And so there are also unknown unknowns. There are things that we don't know that we don't know. And so it's a new frontier. And so it's important to answer what we know and what we don't know, and keep that in mind. Sounds confusing, I know, but we don't have all the answers, and I think it's incredibly important for you to understand that we don't have all the answers when it comes to these drugs. I have a good friend who works for plaintiffs' attorneys who spend a lot of time suing these manufacturers, and it's probably because of these side effects. I don't know the details of the cases. I think they work for a lot of people. I think that they've helped a lot of people, but I think that we need to be very careful in their use. So knowledge is power, in my view, and so we're going to talk about what these drugs are and what we know that they do. What we don't know that they do is the biggest problem, and so that's where a lot of research is focusing. So I just want you to keep in mind that we don't have all the answers, as much as we'd like to. So let's turn now and talk about some specific SSRIs. We'll talk about 3 different kind of groupings that work similar to one another. Fluoxetine, which is, of course, Prozac, and then paroxetine, sertraline, fluvoxamine, which have a similar profile, and then Citalopram and Citalopram, which obviously they're similar because they're very similar names. So let's talk about fluoxetine or Prozac. Probably slightly less efficacious than tricyclics, but often is the first to be prescribed. It's our first line antidepressants, one of the most common ones people go to. It's well known, it's cheap because it's available as a generic. It's got about a 2 to 4 day half-life, but it does have an active metabolite that has a half-life of 14 days. So remember, it takes 5.5 to 6 half-lives to reach steady state. So if we just focus on the fluoxetine itself, that means it's going to take 11 to 7, sorry, my math in my head. It's going to take 11 to 24 days to reach steady state just for fluoxetine. Now, when we talk about the active metabolite, which has a half-life of 14 days, we're talking about 10 weeks, at least, to reach steady state. So it's a long haul. The reason why it takes a while to reach steady state, and why it takes a while for these drugs to actually work. Because not only does it take a while for us to get the neuronal changes we want, it takes a while to even reach steady state. It's also why it takes a long time to come off these drugs, and why you have to step down them, because once you've reached that steady state, it's important to maintain it. So almost 3 months to reach steady state for most people, and it will also take about 3 months for this drug to completely leave your body. Keep that in mind. So side effects of Prozac include Serotonin Syndrome, anxiety, insomnia, and sexual dysfunction. This drug comes in a variety of preparations. It comes obviously as generic, which makes it palatable for a variety of people to afford. It comes as Prozac, of course. It comes as Serotonin, which is prescribed for premenstrual dysphoric disorder. No reason you can't use the generic and prescribe it following the Serotonin guidelines. There's Prozac Weekly, which is obviously an extended release. And then there's Symbyax, which is fluoxetine and olanzapine, which is for treatment of depressive disorder as part of bipolar disorder. So this is a combination drug used for treating both mania and depression. Sorry. And it's also for treatment of psychotic depression. So it's a good combination drug for people in bipolar disorder or for psychotic depression. So that's Prozac. Been used extensively, and certainly is still in use quite a bit. Sertraline, or Zoloft, is our next drug to talk about. It's 4.5 times more potent and selective than Prozac, so oftentimes it works better for people and with fewer side effects. We reach steady state in a much shorter period of time because it has a shorter acting and less active metabolite. So we reach steady state in about 5 to 7 days instead of 3 months as with Prozac. It's effective in treating depression, dysthymia, which is of course a longer term but less severe form of depression, and then of course anxiety disorders. Like all SSRIs, seem to be effective in treating anxiety disorders in addition to depression. It has also been reportedly effective in treating comorbid post-traumatic stress disorder and alcohol dependence. When we get to alcohol and other substances, I'm going to post some links to some videos to watch. There's a really great episode of Intervention that looks at how veterans of the War on Terror in particular who have post-traumatic stress disorder oftentimes end up with alcohol dependence or other substance abuse. And Zoloft is one that might be effective in treating PTSD along with alcohol dependence. Paroxetine or Paxil, another very commonly used drug, therapeutically effective in treating depression and anxiety disorders. In fact, it's more often used for anxiety disorders than depression. It is FDA approved for treating depression, obsessive compulsive disorder, and panic disorder. It's more selective than fluoxetine and has a half-life of about 24 hours. Nice, convenient half-life, reach steady state in 5.5 to 6 days. So relatively similar to the half-life of Zoloft. I want to take a little bit of a look at some data about the effectiveness of Paxil. We're going to take a look at some data from the STAR-D study here in a bit. In this particular study, 116 patients who were greater than 70 years old, so older adults, were enrolled in a placebo-controlled, double-blind, 2-year study. They were assigned to one of several groups, paroxetine or Paxil with psychotherapy, which was found to be more effective than just paroxetine with just clinical management, or placebo with psychotherapy. So we have 3 groups: drug with psychotherapy, drug with just clinical management of the drug, or placebo with psychotherapy. And the most effective was drug with psychotherapy. And the therapy in this case was weekly interpersonal psychotherapy. Most important thing we want to look at is recurrence rate in the groups. There was a 35% recurrent rate of depression in those treated with Paxil and psychotherapy, 37% in Paxil and clinical management. So marginal gains by adding psychotherapy. There may be some individual differences there that we might want to look at. But 58% relapse or recurrence in those with placebo and clinical management. That is the general control trial. So obviously the drugs are effective in preventing the recurrence of depression. Turn next to talk about Luvox or fluvoxamine. It's a derivative of fluoxetine, which is Prozac. It's available for treatment of obsessive compulsive disorder. That's what it's approved for. Also an effective antidepressant, but these are all off-label uses. Other off-label uses include post-traumatic stress disorder, dysphoria, Parkinson's disease, social anxiety disorder, and autism. When we talk about an off-label use, this is when a doctor will prescribe a drug for use for which a drug is not approved. There's nothing illegal about that. It's just called an off-label use. And this occurs all the time with a variety of drugs. Whether it's a good idea or not is another question, but it is often used for that particular, these particular disorders. Selective or Citalopram is our next drug. It's been available in Europe since 1989, the U.S. since 1998. It's used in treating major depression disorder, social phobias, Parkinson's disease, and obsessive compulsive disorder. I'm sorry, that's probably panic disorder. Social phobia, panic disorder, obsessive compulsive disorder. All these are anxiety disorders and major depressive disorder. These effects are the same as all other SSRIs for Selective, but does not induce drug interactions as it does not inhibit hepatic drug metabolizing enzymes. One of the things that you'll see in your textbook that's important to understand about SSRIs is they do have effect on some of the enzymes we talked about that break down drugs. And some of the drugs will actually block converting some pain-relieving drugs into the appropriate drugs we need in the brain. So for example, hydrocodone and codeine both have to be converted into hydromorphone in order for us to get any pain relief from them. Well, some SSRIs block the cytochrome P450 enzymes that are responsible for making that transformation. And so we'll talk more about that when we get to talking about pain drugs. The last drug to talk about in this class is Lexapro. It's an active isomer of Citalopram, which is the drug we were just talking about, but it's twice as potent, so we can use half the dose. And it's equivalent to Citalopram in treating panic attacks in the elderly. It's effective certainly in treating those kinds of anxiety and panic attacks that might be associated with any anxiety disorders. So those are the SSRIs. Question becomes, what do we do if an SSRI doesn't work? Because these are our first class of drugs. And so again, I want to talk briefly through, and I've cut this down significantly from what your book talks about, which is called the STAR-D study, which is the Sequence Treatment Alternatives to Relieve Depression. And what they did is they moved people through various phases. And I'm not going to go through the entire research design because it's a huge design, far more complicated than I want you to understand, but I do want you to see that there is evidence about what to do in the event that an SSRI doesn't work. So treatment strategy for after an SSRI failure. So if you want to look this up, here's the information from the New England Journal of Medicine, 2006. In the first phase, patients with major depression were treated with Citalopram. 30% of those patients then reached remission. They studied the 727 adults who had no remission of symptoms or could not tolerate Citalopram, so people who did not go into remission or could not tolerate the drug. Studied the effect of medication switch to a 14-week trial to switch to Bupropion, sertraline, or venlafaxine. What they found is remission rates were 25% for each of the three drugs, so 1 in 4 patients with unsuccessful response to one SSRI responded to a second-step drug. Any of these three is a reasonable second choice. We're going to talk about these drugs, particularly Bupropion, here in a bit, because it's a very different drug. So any of these three drugs might be a good second choice drug. Unfortunately, the discouraging part of this is about half of depressed patients did not achieve any remission. And so that's one of the things we want to think about is whether or not, what to do with this other half of drugs. Sometimes people get switched to a third drug, and eventually you get up to pretty good remission rates. So there is hope. So start with an SSRI, maybe move on to one of these dual-action antidepressants that we're going to talk about. Next, which include Remeron and Cymbalta. Metrazapine or Remeron increases norepinephrine and 5-HT transmission via a complicated presynaptic mechanism. It's a specific stimulant of 5-HT1 receptors. 5-HT2 and 5-HT3 receptors are specifically blocked. There is some histamine blockade, so it's highly sedative, and unfortunately increases appetite and body weight. So there are some significant side effects to this particular drug. It has a half-life of 20 to 40 hours, so it's suggested that patients take this at bedtime so that the sedating activities occur at night, and then by the time the next day comes around, they're ready to take the next dose. And then, of course, after about 6 to 10 days, they'll reach steady state. Cymbalta is much, more on metrazapine. It has been shown to be effective in older adults. In this particular study, these folks were 85 years old or older, was safe and effective. In a 12-week open-label study with 50 patients, the average dose was 20 milligrams at bedtime. In these older adults, they gained about 1.5 pounds or 1.3 pounds. And this, in depressive nursing home patients, was found to be beneficial because oftentimes getting those patients to eat is difficult. So let's move on to talk about Cymbalta or duloxetine. It does reduce both depression and anxiety. Whether or not it's better than some of the other drugs we'll talk about is questionable, but it certainly has been effective in reducing both depression and anxiety. It importantly also reduces physical symptoms of pain, backache, joint and muscle pain, back and shoulder pain. You've probably seen the commercials about pain going along with depression. Well, Cymbalta is particularly effective at treating that. Belief is it will be used in depression, anxiety, chronic pain, chronic fatigue syndrome, and so on, where pain and depression occur comorbidly. So it might be a good choice, drug choice for some people who fall into these categories. Half-life is about 12 hours, but giving it once a day actually works fine, even though it has that shorter half-life. It turns out the amount of drug needed to reach relief is relatively low. There have been some newer studies that show that this drug can be used for treatment of generalized anxiety disorder, or GAD, based on 3 funded studies in 800 non-depressed patients with generalized anxiety disorder. The depression was significantly decreased, and their global functioning was significantly improved. So Cymbalta can be used for anxiety disorders as well. There are some side effects, though. Nausea, dizziness, and somnolence are potentially significant side effects of Cymbalta. It's a relatively new drug. Still some research to be done, but seems to be effective for some people, particularly those with generalized anxiety disorder comorbid with depression. Finally, there are some specific norepinephrine reuptake inhibitors that are only norepinephrine reuptake transporter inhibitors. They seem to be as effective as fluoxetine and may be better in regards to social functioning, self-motivation, and psychological well-being. Their side effects are mainly anticholinergic, including dry mouth, sweating, tachycardia, constipation, and urinary retention. But importantly, these have actually been shown to be cognitive enhancers, and the effect is probably independent of their antidepressant action. In fact, some of these drugs have been used to treat sleep disorders, in which people have a hard time staying awake, and have also been shown to actually improve cognition. Questionable whether or not those effects are significant or long-term, but they do seem to actually help cognition in some people. Strattera is also a norepinephrine reuptake inhibitor, which is atomoxetine. I'm sure most of you have used, or not used, have heard of this drug, or know people that use it. It's approved for use in ADHD in children and adults. Has been used as an adjunct in fibromyalgia, that is, it seems to be both antidepressant and analgesic, and has been shown effective in treating post-traumatic stress disorder. So these norepinephrine reuptake inhibitors seem to have some really important and significant clinical effects. We'll talk more about Strattera later on in the semester. Wellbutrin, or bupropion, which is also sometimes known as Zyban, is another important drug that falls into sort of an odd class. It's not a serotonin, nor is it a norepinephrine drug. It's actually a dopamine reuptake inhibitor. In fact, it has a cocaine-like action, but it has an anti-craving action. So seems to be well used in terms of trying to limit cravings, which is why it's often used as Zyban, which is to treat nicotine dependency. So it's used to treat anxiety, restlessness, tremor, and insomnia. It's used to treat depression, ADHD, and nicotine dependency. It can cause anxiety, psychosis, and seizures, so you want to be very careful for this particular drug. So it's a good antidepressant. It's good for treating nicotine dependency, possibly ADHD as well, but can be anxiogenic and can cause restlessness and insomnia. Can improve sexual function and is not effective for panic disorder. So let's restate that. This is a dopamine reuptake inhibitor with cocaine-like action, but also has an anti-craving action, which is important. So people don't crave taking this drug, so it's not addictive. Has some side effects, including anxiety, restlessness, tremor, and insomnia. Can be used to treat depression, ADHD, and nicotine dependency, but can cause anxiety, psychosis, and seizures, but can also improve sexual functioning. And this is definitely not effective for panic disorder. So it's important for us to keep that in mind, that this drug is good for some uses. There are better drugs for nicotine dependency, which we'll talk about later on, but this can be used for that. All right, our last drug to talk about under this are serotonin 5-HT1 agonists. Buspar, or Buspar, is a prototype 5-HT1 agonist. I believe this drug is actually available now. It's anxiolytic and antidepressant. Interestingly, its effects can be improved with grapefruit. Remember we talked about grapefruit earlier. And might be best in combination with another SSRI. There's a newer 5-HT1 agonist called Remeron ER, shown effective as a monotherapy for major depression, but was being withheld by the manufacturer. So there is light on the horizon for some new, much more selective drugs. So Buspar might be a good choice and maybe good in conjunction with an SSRI. I want to talk in our next session about new directions in antidepressants. These are the SSRIs and some of their related drugs. We'll talk about some new directions in research in this area.